Welcome. For those of you joining us, you are stepping into a comprehensive Level 7 academic review. We are designing this specifically for you, whether you are preparing for your FRCS Exit Examination in general surgery, or you just demand the absolute highest tier of anatomical and oncological rigor in your practice.
Right, exactly.
This is our deep dive into the surgical oncology and, well, the pathophysiological landscape of lymphoma. And we are going to dispense with the standard colloquial introductions today. In the high-stakes environment of an MDT, a multidisciplinary team meeting, or indeed the oral examination itself, precision is everything.
It's paramount, yes.
Okay, let's unpack this. We are tasked today with synthesizing a truly formidable volume of contemporary literature. We are looking at the 2025 National Non-Hodgkin Lymphoma Audit Data, foundational diagnostic frameworks from StatPearls, and of course the stringent clinical pathways mandated by NICE guidelines.
Right. And, thank you for having me. It really is a privilege to participate in this kind of systematic review because as surgeons, we frequently encounter lymphoma not as some neatly packaged diagnosis from a textbook.
As a completely undifferentiated mass.
Precisely. An undifferentiated mass, an acute surgical abdomen, or perhaps a complex diagnostic dilemma in a severely immunocompromised patient. So our objective here is to rigorously deconstruct the etiology, the diagnostic hierarchy, the operative technicalities of the surgical biopsy itself, and naturally, the rapidly evolving evidence base surrounding modern imaging and systemic therapies.
What's fascinating here is how all these elements must interlock for the patient to actually survive the pathway. So let us commence with Section 1, Etiology and Applied Anatomy.
Okay.
I require a meticulous breakdown of the cellular origins of this disease. Now, we know lymphoma is broadly defined as a heterogeneous group of malignancies.
Yes, arising from the clonal proliferation of B cells, T cells, and natural killer cells.
Right, and constituting roughly 5% of all malignancies.
Mm-hmm.
But to truly understand the pathology, we have to master the microanatomy and the embryology. So walk me through the fundamental structural and cellular environment from which these malignancies actually arise.
Well, to understand the pathogenesis of lymphoma, you really have to first appreciate the architecture of the secondary lymphoid organs, primarily the lymph node.
Take us back to the embryology first.
Right. Embryologically speaking, the lymphatic system develops right at the end of the 5th week of gestation.
From the mesenchyme.
Exactly. From 6 primary lymph sacs derived from the mesenchyme. And as these develop into the complex nodal networks we see in adult patients, they establish highly specific architectural zones.
So if we were to examine a histological cross-section of a normal lymph node, what are we seeing?
You would observe an outer capsule, subcapsular sinus, the cortex, the paracortex, and finally the medulla. But the critical zone for lymphomagenesis, particularly for the B-cell lymphomas, which, as you know, comprise the vast majority of these cases, is the germinal center within the cortex.
Okay, let's stop there. Elaborate on the germinal center. Why is this specific microscopic locus so exceptionally prone to oncogenic transformation? I mean, it's essentially a focal point of genetic instability, isn't it?
It is. The germinal center is essentially a highly dynamic, inherently unstable microenvironment. This is where B lymphocytes undergo antigen-driven somatic hypermutation and a class switch recombination.
Explain that mechanism for the listener. What triggers that instability?
Well, when a naive B cell encounters a foreign antigen, it migrates to the primary follicle and it forms a germinal center. Here, the cell intentionally, and this is the key word, intentionally introduces point mutations into the variable region of its immunoglobulin genes.
So it's actively trying to mutate.
Exactly. The physiological objective is to produce an antibody with a higher affinity for the antigen. It's an evolutionary arms race inside the node. And this is facilitated by an enzyme called activation-induced cytidine deaminase, or AID.
But playing with DNA like that comes with consequences.
Massive consequences. This process of intentionally cleaving, mutating, and splicing DNA is incredibly hazardous. It creates continuous double-strand DNA breaks.
Right.
So if the cellular DNA repair mechanisms fail, or if they make a critical error during this chaotic process, well, you generate chromosomal translocations.
A structural failure at the molecular level.
Precisely.
Okay, let's apply this to the classic translocations we see in the non-Hodgkin variants. Detail the specific genetic aberrations driving follicular lymphoma, mantle cell lymphoma, and Burkitt lymphoma. And do not merely list the translocations. I want you to explain the mechanical disruption to the cell cycle that drives the oncogenesis.
Certainly. So if we look at follicular lymphoma, we observe the T14-18 translocation.
Between chromosome 14 and 8.
Yes. This reciprocal translocation juxtaposes the BCL2 gene on chromosome 18 directly with the immunoglobulin heavy chain enhancer region on chromosome 14.
And what is the normal function of BCL2?
BCL2 is a potent anti-apoptotic protein. Normally, a B cell in the germinal center that fails to produce a high-affinity antibody is supposed to undergo programmed cell death apoptosis. It's supposed to be cleared out.
But the translocation prevents that.
Exactly.
Oh.
Because the BCL2 gene is now sitting right next to the highly active immunoglobulin promoter, a promoter that is constantly screaming at the B cell to produce proteins, the BCL2 gene becomes constitutively overexpressed.
It effectively becomes immortal.
It does. It becomes functionally immortal. It simply refuses to die, which leads to this slow, very indolent accumulation of malignant cells over a period of years.
Right. Contrast that indolent mechanism with the hyperproliferative nature of Burkitt lymphoma, because they present entirely differently on the ward.
They do. In Burkitt lymphoma, the structural error is the T814 translocation. This moves the c-Myc proto-oncogene from chromosome 8 to that exact same active immunoglobulin heavy chain locus on chromosome 14.
So c-Myc is driving this one.
Yes, and unlike BCL2, which just prevents death, c-Myc is a powerful transcription factor. It acts as a primary accelerator for the cell cycle.
Pushing it out of the resting phase.
Right, driving the cell relentlessly from the G1 phase directly into the S phase. The overexpression of c-Myc forces the B cell into continuous, completely unregulated proliferation.
So the tumor growth rate is exponential.
The proliferation index approaches 100%. And histologically, this is what gives you that classic starry sky appearance.
Let's describe that for the candidates. The starry sky.
Well, the sky consists of a dense, dark sheet of rapidly dividing basophilic malignant B cells. And the stars...
The stars are the macrophages, correct?
Exactly. Tangible body macrophages. They are the immune system's cleanup crew, feverishly ingesting the massive amount of cellular debris that gets generated by this exceptionally high turnover rate.
Fascinating. And briefly, mantle cell.
For mantle cell lymphoma, we see a T1114 translocation. That one affects cyclin D1, which is another key cell cycle regulator, driving an aberrant proliferation, though not quite at the blistering pace of Burkitt's.
Excellent. Now, let us address the etiological triggers, because these translocations don't just happen in a vacuum. The literature explicitly links specific environmental and infectious agents to these genetic failures. So, discuss the pathogenesis of malt lymphoma and the role of viral oncogenesis. And I want you to specifically consider the immunocompromised patient, as this is highly relevant for the surgical candidate managing complex patients on the ward.
Absolutely. The overarching pathophysiological principle here is chronic antigenic stimulation.
Meaning the immune system is constantly being provoked.
Right. So in the case of malt lymphoma mucosa-associated lymphoid tissue lymphoma, specifically of the stomach, the trigger is typically a chronic persistent infection with Helicobacter pylori.
H. pylori.
Yes. The persistent bacterial presence forces continuous localized immune response. So you have years of sustained B-cell division in the gastric mucosa.
And mathematically, more division means more chances for errors.
Exactly. It vastly increases the statistical probability of a genetic error occurring during that somatic hypomutation phase, eventually leading to a T1118 translocation, which creates an autonomous malignant clone.
A clone that no longer requires the bacteria to grow.
Precisely. You could eradicate the H. pylori at that point, but the lymphoma would persist.
And regarding viral agents and immunodeficiency, we see these cases constantly on surgical consults.
Epstein-Barr virus, EBV, is deeply integrated into the etiology of both Burkitt lymphoma and classic Hodgkin lymphoma.
How does it infiltrate the cell?
EBV directly infects the B lymphocytes via the CD21 receptor. Once inside, the viral genome expresses latent membrane proteins, specifically LMP1, which mimics CD40 signaling.
So it bypasses the normal activation pathways.
It essentially tricks the B cell into a state of continuous activation and survival, entirely without the need for an actual foreign antigen.
So how does this manifest in, say, the HIV-positive patient or the solid organ transplant recipient?
In those immunocompromised scenarios, what we are observing is a catastrophic failure of immune surveillance. Normally, the human immune system, specifically cytotoxic T cells and natural killer cells, constantly surveys for and eliminates these emerging malignant clones.
Right. They are the body's internal police force.
But in a patient with advanced HIV and a severely depleted CD4 count, or a renal transplant patient who is maintained on calcineurin inhibitors and antimetabolites, that entire surveillance network is disabled.
The police force is off duty.
Completely off duty. So if an EBV-infected B cell begins to proliferate, there are absolutely no T cells available to recognize it, let alone destroy it.
And the clinical result.
You see extremely aggressive presentations, things like primary central nervous system lymphoma or post-transplant lymphoproliferative disorder.
And the surgical implication for our listeners.
The surgical implication is absolute. If you have any solid mass, a bowel obstruction, or persistent lymphadenopathy in an immunosuppressed patient, you must approach it with a high index of suspicion for an aggressive, high-grade lymphoma. You cannot simply assume it's a reactive node or a standard surgical issue.
A sound anatomical and etiological foundation. Let's transition now to Section 2, the Diagnostic Hierarchy. As surgeons, we are the ultimate gatekeepers of tissue diagnosis.
We are.
But before we even discuss the operative intervention, we must rigorously evaluate the clinical presentation. So detail the classic presentation of lymphoma, and I want you to critically analyze the associated systemic signs.
The hallmark presentation, undoubtedly, is progressive lymphadenopathy.
Usually specific basins.
Yes, most frequently manifesting in the cervical, axillary, or inguinal basins. But what's crucial is the physical characteristic of the node. Unlike the tender, erythematous, acutely swollen nodes you'd associate with reactive lymphadenitis, say, from a bacterial pharyngitis, lymphomatous nodes are characteristically firm, rubbery, and completely painless.
Right, the painless lump. That's what
Yep.
makes patients ignore them for months.
Exactly. They may present as discrete entities initially, but as the disease progresses and breaches the nodal capsule, they can become matted, and they eventually fix to underlying fascial and vascular structures.
And we must also be vigilant for eponymous presentations, mustn't we? Consider Virchow's node.
Ah, yes. Virchow's node, located in the left supraclavicular fossa. While it is classically associated with gastric adenocarcinoma via Trizier sign, it can absolutely be the primary presentation for a retroperitoneal or abdominal lymphoma draining superiorly via the thoracic duct.
Very good. Now, discuss the systemic manifestations. Specifically, the prognostic triad we refer to as B symptoms, and explain their pathophysiological origins. Because they are not merely an afterthought during your history taking.
No, they are strictly defined criteria that carry immense prognostic weight. The B symptoms are unexplained, cyclical fevers exceeding 38 degrees Celsius, drenching night sweats, and by drenching, we mean severe enough to necessitate a change of night clothes or bed linen, and an unintentional loss of more than 10% of total body weight over the preceding 6 months.
When a patient has these, what does it mean for their staging?
The presence of these symptoms fundamentally alters the Ann Arbor staging, adding the B designation, and it usually portends a much more aggressive biological behavior from the tumor.
But why do they happen? Pathophysiologically. They aren't directly caused by the mechanical presence of the tumor mass, are they?
No, they are perineoplastic. They are caused by the perineoplastic release of pro-inflammatory cytokines by the malignant cells, notably interleukin-6, tumor necrosis factor alpha, and interleukin-1.
Let's trace the cytokines. Where do they go?
These circulating cytokines cross the blood-brain barrier, and they act directly on the thermoregulatory center in the anterior hypothalamus. They actually elevate the body's basal temperature set point.
Inducing the fever.
Yes, and inducing profound vasomotor responses, which manifest as those characteristic drenching sweats when the body tries to cool back down.
And the weight loss.
The weight loss is multifactorial. It's driven by the hypermetabolic state of the rapidly dividing tumor cells, but also by the severe conchectic effect of TNF-alpha, which actively suppresses appetite and alters lipid metabolism.
And for completeness, what about the fever in Hodgkin lymphoma?
In Hodgkin lymphoma, you may occasionally see the rare Pell-Ebstein fever that's characterized by alternating periods of high fever and completely normal temperatures, often lasting days or even weeks at a time.
Okay, let us expand our diagnostic view beyond just the peripheral lymph node. Consider the extranodal presentations. Suppose you're evaluating an elderly male patient on the admission ward. He presents at the A&E with acute visual disturbances, profound confusion, and severe epistaxis nosebleeds. His initial blood work reveals massive hyperproteinemia. How does this fit into our oncological discussion today?
Well, that clinical vignette is highly suggestive of Waldenstrom macroglobulinemia.
What's
It is a rare, low-grade lymphoplasmacytic lymphoma. The malignant B cells in this specific condition exhibit plasma cell differentiation.
Meaning they act like plasma cells and secrete antibody.
Exactly. Their primary pathological function becomes constitutively secreting massive quantities of a monoclonal immunoglobulin M, or IgM.
An IgM is a huge molecule.
It is a massive pentameric molecule. When it accumulates in the intravascular space at these volumes, it drastically increases both the oncotic pressure and the physical viscosity of the blood.
Hence the hyperviscosity syndrome.
Right. The hyperviscosity syndrome results in sluggish microvascular perfusion. In the central nervous system, this hypoperfusion causes the confusion, somnolence, and headaches you mentioned.
And the visual changes.
In the retinal capillaries, the thick blood leads to venous engorgement, retinal hemorrhages, and blurred vision. And in the delicate nasal mucosa, the sludging combined with impaired platelet function from the protein coating results in spontaneous severe epistaxis.
A thorough differential. Now, let us address the critical juncture of surgical diagnosis. The NICE guidelines in the UK are unequivocal on this matter. We require a precise histological diagnosis to determine the specific subtype and grade before anyone touches chemotherapy. So discuss the diagnostic utility, or the lack thereof, of fine needle aspiration versus core biopsy versus excision biopsy. I want you to defend the gold standard.
The fundamental tenet of lymphoma diagnosis, and we must stress this to every surgical trainee, is that cytological evaluation alone is grossly inadequate.
You're referring to fine needle aspiration?
Yes, FNA. It utilizes a 21 or 23 gauge needle to aspirate individual dissociated cells. Now, while an FNA is highly sensitive for diagnosing a squamous cell carcinoma metastasis in a neck node or an adenocarcinoma,
It is virtually useless for lymphoma.
it is completely incapable of differentiating between the dozens of complex lymphoma subtypes. As we established in our anatomical discussion, the classification of lymphoma relies heavily on the spatial architecture of the node.
Whether the follicle is preserved, destroyed, or expanded.
Right, and FNA completely obliterates that architecture. It's akin to analyzing individual bricks to determine the architectural style of an entire building. You just can't do it. Furthermore, it fails to provide sufficient tissue for the mandatory immunohistochemistry and genetic stratification.
Okay, what about the core needle biopsy? It's often favored by our interventional radiology colleagues because it avoids a general anesthetic.
A core needle biopsy, utilizing a 14 or 16 gauge needle, does provide a solid cylinder of tissue, so it is undeniably superior to an FNA. But it is considered acceptable only in clinical scenarios where an excision biopsy is anatomically hazardous or inaccessible.
Give me an example.
For instance, an isolated retroperitoneal node encasing the aorta, or a very deep mesenteric mass where a laparotomy just for biopsy carries too much morbidity. However, we have to recognize that the core biopsy is still highly susceptible to sampling error.
Especially in Hodgkin's.
Exactly, particularly in classic Hodgkin lymphoma. In those nodes, the diagnostic bilobed Reed-Sternberg cells may constitute only 1 to 2% of the total cellular population within the node.
The rest being just a reactive, inflammatory infiltrate.
Right, so a core needle can very easily pass through the node, miss the malignant cells entirely, and yield a false negative result, delaying treatment.
Therefore, the definitive gold standard.
The absolute gold standard remains the intact surgical excision biopsy of the largest, most clinically suspicious lymph node.
Why the whole node?
By providing the entire node with its capsule intact, the pathologist can meticulously evaluate the global architecture, they can identify capsular invasion, and crucially, they can perform exhaustive fluorescence in situ hybridization, or FH.
The genetic mapping.
Yes, this genetic mapping is strictly required to identify aggressive double-hit or triple-hit lymphomas, which possess concurrent translocations in MYC, BCL2, and potentially BCL6 genes.
And finding those changes everything.
Identifying these high-grade variants alters the chemotherapeutic approach immediately from day one. You simply cannot compromise on tissue volume when the stakes are that high.
Precisely. This transitions us perfectly to Section 3, the evidence base and imaging. We've secured the tissue, we have the histological diagnosis. The imperative now is staging. For decades, computerized tomography CT was the workhorse. Today, the landscape is entirely dominated by positron emission tomography fused with CT. So, candidate, explain the precise biochemical mechanism of FDG-PT, and critique its utility and its limitations in surgical staging.
Fluorodeoxyglucose positron emission tomography, FDG-PET, represents a massive paradigm shift. We move from pure anatomical imaging to metabolic functional imaging.
How does the tracer work?
The radiotracer, fluorine-18 fluorodeoxyglucose, is essentially a radioactive glucose analog. Malignant lymphomas, particularly the high-grade variants like diffuse large B-cell lymphoma, exhibit the Warburg effect.
Meaning they rely heavily on aerobic glycolysis.
Yes, to fuel their rapid cellular proliferation. Consequently, they vastly upregulate GLUT1 and GLUT3 glucose transporters on their cell surface. So when we inject FDG intravenously, it is aggressively transported into the tumor cells.
Detail the intracellular fate of that FDG molecule. This is where the diagnostic elegance really lies.
It is quite elegant. Once inside the cytosol, the FDG molecule is phosphorylated by the enzyme hexokinase to form FDG6-phosphate.
Same as normal glucose.
Exactly. But here's the trick. Because the FDG molecule lacks a hydroxyl group at the 2' position, it cannot proceed any further down the glycolytic pathway. It cannot be processed by phosphohexosisomerase.
And gets stuck.
Furthermore, tumor cells generally have very low levels of glucose 6-phosphatase, which is the enzyme required to reverse that initial phosphorylation. Therefore, the radioactive FDG6-phosphate becomes metabolically trapped inside the cell.
It accumulates.
It accumulates massively, and as the fluorine-18 isotope decays, it emits positrons. These annihilate with local electrons, producing paired gamma rays that the PT scanner detects. We then overlay this functional heat map onto a high-resolution CT scan to provide precise anatomical localization.
The mechanism is elegant, yes, but the clinical application is fraught with pitfalls. A senior surgeon must interpret these scans critically. You cannot simply accept a radiology report blindly. Let us dissect the false positives, discuss how granulomatous disease and physiological variants can mimic lymphoma, leading to potential mismanagement.
Right. The primary limitation of FDG-PE is that while it is highly sensitive for metabolic activity, it is not perfectly specific for malignancy.
Anything burning sugar lights up.
Exactly. Any physiological or pathological process that upregulates glucose consumption will sequester the tracer. Granulomatous diseases such as active mycobacterium tuberculosis infection or systemic sarcoidosis are prime examples.
How do they present on the scan?
The dense aggregates of activated macrophages and epithelioid cells within a granuloma consume massive amounts of glucose to fuel their inflammatory response. On a PET scan, a mediastinal tubercular lymph node will demonstrate intense FDG avidity. It is completely indistinguishable from a lymphomatous mass.
So what's the clinical safeguard?
This necessitates rigorous clinical correlation. You must prioritize travel history, exposure risks, and potentially pursue a diagnostic mediastinoscopy or a staging laparoscopy for tissue confirmation if the diagnosis remains ambiguous.
Consider the patient preparation parameters. The imaging guidelines strictly mandate a 4 to 6 hour fast and an absolute prohibition on exercise. What are the physiological consequences of non-compliance?
Failure to adhere to the fasting protocol leads to competitive inhibition.
Walk us through it.
If a patient consumes a meal, their serum glucose rises, which triggers endogenous insulin release. Insulin actively drives the unlabeled dietary glucose into skeletal muscle, adipose tissue, and the myocardium. So if the radio-labeled FDG is injected in this state, it has to compete with the abundant normal glucose for the GLUT transporters. The tumor's uptake will be masked.
And the background noise increases.
Massively. The insulin will drive the FDG into the healthy muscle tissue, drastically increasing the background physiological uptake, which can easily obscure a subtle malignant lesion. Similarly, rigorous exercise prior to the scan upregulates muscular glucose demand, leading to intense, diffuse skeletal muscle uptake.
I want to push you on a specific challenging scenario frequently encountered in the post-treatment phase. You have a 22-year-old female patient. She recently completed 6 cycles of ABVD chemotherapy for classic Hodgkin lymphoma. Her end-of-treatment PT-CT shows complete resolution of her cervical and axillary disease.
Good.
But it reveals a new, intensely FDG-avid, distinctively bilobed mass in the anterior mediastinum. The junior doctor on your team is preparing to refer her for salvage chemotherapy, assuming a catastrophic relapse. Intervene. What do you do?
I would halt that referral immediately. That clinical picture is highly pathognomonic for benign thymic hyperplasia. We often refer to it as thymic rebound.
Why does it happen?
In children and young adults, the thymus gland, situated in the anterior mediastinum, is the primary site for T-cell maturation. During intensive cytotoxic chemotherapy, the profound systemic stress and the direct myelosuppression cause severe thymic atrophy.
It shrinks down to almost nothing.
Right. But once the suppressive agents are withdrawn, the immune system mounts a vigorous recovery to replenish those depleted T-cell reservoirs. The thymus undergoes a massive, rapid hypertrophic rebound.
And because it's growing quickly.
Because this process involves intense cellular proliferation, the thymus becomes highly hypermetabolic and intensely FDG avid. A skilled nuclear medicine physician and a competent surgeon must recognize the classic inverted V or bilobe morphology of the thymus, and they must correlate it with the temporal relationship to the cessation of chemotherapy.
Thus, averting an unnecessary surgical biopsy, or worse, a devastating misdiagnosis of relapse. Excellent. You must also be aware of the effects of granulocyte colony stimulating factor, or GCSF, which we routinely administer to combat chemotherapy-induced neutropenia.
Yes, that will cause intense, diffuse uptake throughout the axial skeleton and bone marrow as the hematopoietic precursors are driven into overdrive.
Right. If the scan is performed too soon after GCSF administration, this physiological bone marrow expansion can be disastrously misread as diffuse osseous metastatic disease. We also have to recognize the impact of brown adipose tissue, which burns glucose to generate heat.
Ah, yes. If a patient shivers in the waiting room, symmetrical, intense uptake around the neck and clavicles can mimic massive nodal involvement. This is why we necessitate the use of warm blankets or even beta blockers prior to imaging.
A crucial point on imaging limitations. Let's consider a further clinical variable, a complex one. You are managing a 28-year-old female, currently in her second trimester of pregnancy, who presents with a rapidly expanding cervical mass. You've confirmed it as Hodgkin lymphoma via your excision biopsy. How does the physiological state of pregnancy alter your staging algorithm, given the absolute contraindication of a radioactive PET-CT scan?
The pregnant patient presents a profound clinical challenge. The ionizing radiation and radioactive isotopes associated with PET-CT and conventional CT are teratogenic. They are absolutely contraindicated, particularly in the first trimester, and generally avoided throughout the entire gestation.
So what are our tools?
In this scenario, we must rely entirely on non-ionizing modalities. We would utilize high-resolution magnetic resonance imaging MRI of the neck, chest, abdomen, and pelvis to assess the anatomical extent of the disease.
But MRI lacks the metabolic functional data of a PT scan.
It does, but specialized sequences such as diffusion-weighted imaging, DWI, can serve as a highly effective surrogate marker for cellular density and tumor activity. This aids in staging without exposing the fetus to radiation.
What about the bone marrow?
A bone marrow tryphene biopsy, which is often omitted in the modern PET-CT era for certain subtypes, becomes strictly mandatory in the pregnant patient. We have to definitively rule out stage 5 disease.
Let us move to the systemic reality. We must contextualize this disease within the framework of our national health infrastructure. Analyze the 2025 National Non-Hodgkin Lymphoma Audit data for England and Wales. What are the macroscopic failures in our current pathway?
The NNHLA data presents a very sobering reality regarding our diagnostic and therapeutic timelines. The 2022 cohort for England alone comprised over 15,400 cases with a median age of 69. But the most alarming metric is the route to diagnosis.
Which was?
28% of these patients, more than 1 in 4, were diagnosed via an emergency presentation, such as the A&E department, rather than through an elective 2-week wait suspected cancer pathway.
This is a critical failure point. As a surgical consultant, how do you explain this high rate of emergency presentation? What are the specific clinical scenarios that drive a patient to the A&E rather than the general practitioner?
The high emergency presentation rate is driven by a dangerous confluence of vague symptomatology and aggressive tumor biology. The initial symptoms of lymphoma lethargy, night sweats, a painless cervical lump are ubiquitous. They are frequently dismissed by both the patient and the GP as sequelae of a minor viral illness.
A trial of antibiotics is prescribed.
Exactly, causing a delay of meds. However, the high-grade subtypes, such as diffuse large B-cell lymphoma or Burkitt lymphoma, have a doubling time measured in days. The disease rapidly outpaces the standard outpatient referral timeline.
So they crash.
They present to the emergency department in extremis. We see them presenting with superior vena cava obstruction from a massive mediastinal mass causing severe facial edema, or acute stridor from airway compression.
What about abdominal emergencies?
We see profound metabolic disarray from spontaneous tumor lysis syndrome, resulting in acute renal failure, or an acute abdominal pain due to an ileocecal intussusception, where a primary gastrointestinal lymphoma acts as a mechanical lead point, dragging the bowel into itself.
The audit also highlights significant deficiencies in therapeutic targets and data collection. Scrutinize the performance against the 62-day systemic anti-cancer therapy target.
Right. The NHS mandated target is for patients to commence systemic anti-cancer therapy, or SACT, within 62 days of the initial urgent referral. In England, the audit revealed that only 55% of patients with high-grade lymphoma actually achieve this target.
Just over half.
In Wales, the figure was a mere 48%. Roughly half of all patients are waiting longer than recommended for highly aggressive cancers. This indicates profound systemic bottlenecks.
Where are the delays?
The pathway is complex. It requires a GP referral, an initial outpatient consultation, a high-quality surgical biopsy, specialized hematopathology review, including FESH, a PET-CT scan, and finally, a multidisciplinary team discussion. Delays in operating theater capacity for the biopsy or critical workforce shortages and specialized histopathology reporting directly translate to potentially fatal treatment delays.
Furthermore, the audit exposes a glaring ethical and operational dilemma regarding missing data. Over one-third of the patient records lacked complete Ann Arbor staging information. How can we meaningfully evaluate our 62-day target compliance or our survival outcomes if we don't even know the stage of the disease we are treating in a third of the population?
We simply cannot. It is a fundamental epidemiological failure. The Ann Arbor staging system is the absolute bedrock of prognostication and treatment selection.
Remind the listeners of the stages.
Stage I indicates involvement of a single lymph node region. Stage 2 indicates 2 or more regions on the same side of the diaphragm acting as the vital anatomical equator. Stage 3 crosses the diaphragm, involving regions on both sides or isolated splenic involvement. And Stage 4 indicates disseminated, diffuse involvement of extralymphatic organs, such as the liver or bone marrow.
So without that data?
Without this data recorded centrally, it is impossible to determine whether a hospital trust failing the 62-day target is suffering from administrative inefficiency or whether they are acting as a specialized tertiary referral center receiving disproportionately complex Stage 4 cases that require extensive medical stabilization prior to initiating toxic chemotherapy. You cannot optimize a system that you refuse to properly measure.
It is a profound limitation. This brings us to Section 4, operative technicalities. Let's bring this back to the reality of the operating theater. You have a 45-year-old male with a 4-centimeter, firm, steadily enlarging lymph node in the posterior triangle of the right neck. An FNA organized by primary care was non-diagnostic, as we expect. The MDT has requested an excision biopsy. Walk me through the meticulous surgical steps of a right cervical lymph node excision biopsy under general anesthesia. Detail the applied anatomy, the fascial layers, and the critical structures you must protect.
Certainly. First, the patient is positioned supine with a shoulder roll placed to extend the neck, and the head is turned slightly to the contralateral side to optimally expose the right posterior triangle.
Define the boundaries of that triangle.
The posterior triangle is bounded anteriorly by the posterior border of the sternocleidomastoid muscle, posteriorly by the anterior border of the trapezius muscle, and inferiorly by the middle third of the clavicle. The roof is formed by the investing layer of the deep cervical fascia, and the floor is formed by the prevertebral fascia overlying the splenius capitis, levator scapulae, and scalene muscles.
Proceed with the incision and dissection.
I would utilize a transverse incision placed precisely within a natural skin crease over the palpable node, guided by ultrasound marking if necessary, to optimize the cosmetic outcome.
And as you deepen the incision.
Following the skin incision, the subcutaneous fat is divided using monopolar diathermy, bringing the platysma or muscle into view. The platysma is carefully incised in the line of the skin incision. Deep to the platysma, we encounter the external jugular vein and the great auricular nerve ascending over the sternocleidomastoid.
How do you manage them?
These should be meticulously identified and preserved, or the vein ligated and divided if it directly impedes access to the node. We then incise the investing layer of the deep cervical fascia to formally enter the posterior triangle.
Excellent. Now, what is the single most critical anatomical hazard in the posterior triangle during this dissection? Failure to identify this constitutes a critical, potentially career-ending error.
The paramount structure to identify and protect is the spinal accessory nerve, cranial nerve O.
Where is it?
It emerges from beneath the posterior border of the sternocleidomastoid, usually at the junction of the upper and middle thirds, and courses obliquely across the posterior triangle to supply the trapezius muscle. It is often located exceedingly superficially, embedded within the very fibrofatty tissue that houses the target lymph nodes.
How do you avoid injuring it?
I would utilize meticulous blunt dissection using a fine curved hemostat working strictly parallel to the anticipated course of the nerve. I would absolutely avoid the use of monopolar diathermy near the expected path to prevent devastating thermal injury. A nerve stimulator can be employed if identification is difficult due to distorted anatomy or previous inflammation.
Good. Now, suppose during your deep dissection, you find that the lymph node is not discrete, but is intimately matted and densely adhered to the internal jugular vein deep to the sternocleidomastoid. What is your strategy? Do you sacrifice the vein to achieve a complete en bloc excision?
Emphatically, no. The objective of an excision biopsy in the context of suspected lymphoma is to provide adequate tissue architecture for diagnosis, not to achieve an oncological R0 resection.
It's a systemic disease.
Exactly. It's treated primarily with systemic chemotherapy, not radical ablative surgery. If the node is densely adherent to a major vascular structure like the internal jugular vein or the carotid artery, attempting an en bloc resection carries an entirely unacceptable risk of catastrophic hemorrhage.
So what do you actually do in the theater?
In this scenario, I would carefully dissect the node away from the surrounding non-critical structures, and if it remains inextricably bound to the vein, I would perform a generous incisional biopsy.
You take a piece.
I would remove a large representative wedge of the node, ensuring I secure at least 1 cubic centimeter of tissue. I would ensure the specimen is sent fresh, unfixed in a dry pot or saline-moistened gauze, directly to the pathology laboratory.
Why fresh? Why not formalin?
To facilitate immediate flow cytometry and cytogenetic analysis, thereby avoiding the denaturing, DNA-destroying effects of formalin.
And the residual bleeding.
Meticulous hemostasis of the residual nodal bed is then achieved, often requiring precise suture ligation or the application of topical hemostatic agents like oxidized cellulose.
A judicious, safe, and highly defensible approach. Let us introduce a further clinical variable. You are asked to perform an inguinal lymph node excision biopsy on a 75-year-old female who is therapeutically anticoagulated with an oral factor XA inhibitor for long-standing atrial fibrillation. She is frail. How does this alter your preoperative preparation and intraoperative technique?
The management of the anticoagulated frail patient requires careful perioperative planning. Given the elective nature of the biopsy, I would liaise with cardiology or hematology to formalize a bridging strategy. However, holding a direct oral anticoagulant for 48 to 72 hours preoperatively, depending strictly on her renal creatinine clearance, is usually sufficient without resorting to heparin bridging.
And intraoperatively. The groin is notoriously tricky.
The surgical anatomy of the inguinal basin is incredibly prone to massive dead space formation and subsequent postoperative hematoma or seroma. Because of her recent anticoagulation, I would employ absolute meticulous surgical hemostasis. I would utilize bipolar diathermy and fine polygalactin suture ligation for every single lymphatic and vascular channel encountered.
Monopolar isn't enough.
Simply relying on monopolar cautery is inadequate here. Upon removing the node, I would actively obliterate the dead space with deep dermal interrupted sutures, tacking the subcutaneous fat to the underlying cribriform fascia. The placement of a closed suction drain may be considered to prevent hematoma accumulation, though it must be balanced against the risk of introducing a retrograde surgical site infection.
And post-op?
Postoperatively, chemical thromboprophylaxis must be reinstituted carefully, balancing the risk of a wound hematoma against the risk of a devastating thromboembolic event.
Comprehensive. Let us move to Section 5. Complications and prognosis. Every surgical intervention carries morbidity. Detail the specific postoperative complications associated with regional lymph node excisions, specifically in the cervical and supraclavicular regions. Categorize a severe complication using the Clavian-Dindo classification system.
Right. Beyond standard surgical site infections and hematoma formation, regional lymph node biopsies carry highly specific anatomical risks. In the anterior triangle or submandibular region, the marginal mandibular branch of the facial nerve is at risk. Iatrogenic injury results in a functionally and cosmetically devastating asymmetrical, drooping lower lip.
And we mentioned the posterior triangle.
Yes, transection of the spinal accessory nerve there is a catastrophic complication leading to shoulder syndrome. This is characterized by profound chronic shoulder pain, a severely winged scapula, and a complete inability to actively abduct the arm above 90 degrees due to trapezius paralysis.
Consider a left supraclavicular node excision, specifically aiming for a Virchow's node. What is the unique complication inherent to this anatomical space?
The specific risk deeply situated in the left supraclavicular fossa is iatrogenic injury to the thoracic duct. It arches anteriorly over the apex of the pleura to empty into the venous confluence of the left internal jugular and subclavian veins. An unrecognized injury during dissection will result in a post-operative chyle leak.
How does that present?
Presenting clinically as a high-volume, milky white output from the surgical drain, rich in lymphocytes and chylomicrons.
Apply the Clavian-Dindo classification to a patient who develops a persistent, high-volume chyle leak requiring total parenteral nutrition, strict bowel rest, and eventual reoperation for right thoracoscopic ligation of the duct.
This represents a severe morbidity. Under the Clavian-Dindo classification, an initial conservative trial utilizing total parenteral nutrition, fasting, and potentially somatostatin analogs would constitute a grade 2 complication, as it requires pharmacological and nutritional intervention beyond basic antiemetics or analgesics.
But the surgery changes that.
Yes, the subsequent requirement for a return to the operating theater under general anesthesia to formally ligate the thoracic duct forcefully elevates this to a grade 5 complication.
Let us examine the prognosis and systemic management once the surgical biopsy has successfully established the tissue diagnosis. Based on the 2025 audit data, outline the therapeutic paradigms and the expected survival trajectories for both indolent and aggressive lymphomas.
The prognostic landscape is heavily bifurcated based entirely on the histological grade. The NHLA data indicates an overall 1-year survival rate of approximately 80%, dropping to 74% at 2 years. But this macro-level data obscures the stark clinical reality of the subtypes.
Give me the indolent scenario.
For an indolent disease such as a localized asymptomatic stage I follicular lymphoma in an elderly patient, the standard of care is frequently watch and wait. We employ active surveillance, monitoring carefully for clinical progression, nodal enlargement, or the onset of B symptoms.
I'm not just treated.
Because of the cumulative morbidity and mortality of cytotoxic chemotherapy often outweigh the immediate threat of an exceptionally slow-growing disease. In these low-grade cohorts, the overall survival rate approaches 90%.
Contrast this conservative approach with the management of an aggressive variant, such as classic Hodgkin lymphoma or a diffuse large B-cell lymphoma presenting in a younger demographic.
For the aggressive variants, the approach requires immediate, intensive polychemotherapy. For classic Hodgkin lymphoma, the standard regimens are AVVD, adriamycin, bleomycin, vinblastine, and carbazine, or the significantly more intense B-Copia regimen favored in certain European centers for advanced disease.
We are also seeing targeted therapies now.
We are witnessing the highly successful integration of targeted immunotherapies. A prime example highlighted in the literature is brentuximab vedotin, an antibody-drug conjugate.
Explain how it works.
It is brilliant in its design. It consists of a synthesized monoclonal antibody engineered to specifically bind to the CD30 antigen.
Which is found where?
It's a protein which is highly and selectively expressed on the surface of the malignant Reed-Sternberg cells. This antibody is covalently linked to monomethyl auristatin E, a remarkably potent antimitotic agent.
It's a toxin.
Exactly. Once the antibody binds to the CD30 receptor, the entire complex is internalized into the cell, and the toxin is released directly into the cytosol. It effectively acts as a guided molecular missile. It selectively destroys the cancer cell while largely sparing the surrounding healthy tissue, significantly reducing systemic toxicity.
And the outcomes?
Despite their rapid, terrifying growth rates, these high-grade lymphomas are highly chemosensitive, and with timely, aggressive intervention, a substantial proportion are completely curable.
Which requires rigorous post-treatment surveillance to definitively confirm the cure. How is the end-of-treatment response quantified by our radiological colleagues?
The response is assessed using an end-of-treatment FDG-PTT scan, formally evaluated using the Lugano classification and the Deauville 5-point criteria.
Detail the Deauville criteria for us.
The Deauville criteria standardize the interpretation globally by comparing the functional FDG uptake in the residual tumor mass to the patient's own physiological background uptake. A score of 1 means no uptake whatsoever. A score of 2 indicates uptake less than or equal to the mediastinal blood pool. A score of 3 indicates uptake greater than the mediastinum, but strictly less than the physiological uptake of the liver.
And clinically?
Scores 1, 2, and 3 are universally considered a complete metabolic response. Crucially for the surgeon to understand, a patient may have a large 5-centimeter persistent fibrotic mass clearly visible on the anatomical CT component of the scan.
But if it's Deauville 2?
If the functional Deauville score is 2, that mass is metabolically inert. It is simply a tombstone of dead scar tissue, and the patient is considered to be in deep remission. We do not rebiopsy a Deauville 2 mass.
We have arrived at Section 6, the final viva. Candidate, this is where we synthesize the basic science, the operative reality, and the cutting edge of oncology. We will dispense with the established guidelines and look to the immediate future. The 2025 Via Medica updates from the European Hematology Association Congress focus heavily on two emerging modalities: total metabolic tumor volume, or TMTV, and circulating tumor DNA, ctDNA. Explain how the integration of these modalities is actively challenging the supremacy of our gold standard PT-CT imaging.
Well, the fundamental limitation of PT-CT lies in its physical spatial resolution. A tumor mass must reach a certain critical macroscopic size and a specific metabolic threshold to become visible against the physiological background uptake of the human body.
It's relatively crude, mechanically speaking.
It is. The emerging paradigm shifts entirely from visual anatomical detection to molecular interception. Circulating tumor DNA, or ctDNA, represents the true frontier of the liquid biopsy.
How does it work in practice?
As lymphoma cells undergo their rapid turnover and eventual apoptosis, they shred their DNA. Tiny fragments of that mutated DNA, the exact translocations we discussed earlier, like T1418, float freely in the patient's blood plasma. Utilizing highly sensitive next-generation sequencing, we can draw a standard peripheral venous blood sample and detect those specific microscopic tumor DNA fragments long before a mass even forms.
How does this specifically outperform a PET scan? Defend this assertion with a clinical application.
The clinical utility of ctDNA lies in its unparalleled, exquisite sensitivity for detecting minimal residual disease, or MRD. If a patient completes 2 cycles of RCH-GO chemotherapy, their interim PET scan might appear completely clear. Visually, they are cured.
But the molecular reality might be different.
Exactly. If highly sensitive ctDNA assays still detect malignant DNA fragments circulating in their blood, we know with absolute certainty that microscopic chemo-resistant clones have survived the therapy. This patient is at an extremely high risk of an imminent clinical relapse.
And if it clears?
Conversely, if the ctDNA clears rapidly from the blood after treatment, it is a profound positive prognostic indicator. The Via Medica data forcefully demonstrates that this molecular clearance is a far more accurate and sensitive predictor of progression-free and overall survival than conventional radioactive imaging alone.
And regarding total metabolic tumor volume, define its utility.
TMTV utilizes advanced AI-driven volumetric software to calculate the exact 3-dimensional volume of all FDG-avid tissue in the entire body. This provides a quantitative, numerical tumor burden rather than just a blunt, categorical Ann Arbor stage.
Just the combining them gives you what?
By combining the vast volumetric anatomical data of TMTV with the highly sensitive kinetic clearance data of a ctDNA blood draw, we can create a hyper-personalized risk stratification for every single patient.
Present a clinical scenario applying this combined approach. I want to see the senior decision-making process in action.
Consider a young 30-year-old patient with aggressive DLBCL. If they present with a massive baseline TMTV, but their ctDNA drops to entirely undetectable levels after just 1 cycle of chemotherapy, they have demonstrated exquisite, rapid chemosensitivity.
So what does the oncologist do?
An oncologist could utilize this molecular data to safely de-escalate their therapy. They might omit the most cardiotoxic agents like anthracyclines or neurotoxic agents, sparing the patient lifelong heart failure or neuropathy without sacrificing the cure.
And the converse.
Conversely, if a patient has a low TMTV on their PT scan, but their ctDNA remains stubbornly elevated throughout their treatment cycles, the doctor knows they are failing at a microscopic level. The multidisciplinary team can immediately pivot away from ineffective chemo and move to radical salvage therapies, such as stem cell transplantation or chimeric antigen receptor T-cell therapy, YRT, before a macroscopic, clinically devastating relapse occurs.
This represents a profound systemic shift. I have a final ethical and philosophical challenge for you to conclude this viva. Based on this relentless molecular evolution, if we project this trajectory forward, are we rapidly approaching an era where the surgical excision biopsy, the very procedure we've spent this session meticulously detailing, becomes entirely obsolete? If we could detect the exact genetic blueprint of the tumor, identify the precise translocations, and monitor its response entirely through a peripheral venous blood draw at a local pharmacy, is surgical intervention destined to become an anachronism in the management of lymphoma? Defend your specialty.
That is, without a doubt, the ultimate existential question facing surgical oncology today. While ctDNA offers revolutionary monitoring capabilities, the complete obsolescence of the surgical biopsy is not imminent.
Why not? The blood test is perfectly sensitive.
A liquid biopsy detects circulating DNA fragments. It is brilliant at identifying what genetic mutations are present, but it cannot currently replace the profound spatial and architectural information derived from examining an intact lymph node under a microscope.
The architecture is still key.
Exactly. It cannot differentiate between an aggressive transformed lymphoma and a low-grade background senescent clone sharing the same mutation with the certainty required to initiate toxic chemotherapy. Furthermore, a substantial tumor mass may be poorly vascularized, encapsulated, or extensively necrotic.
Meaning it wouldn't shed into the blood.
Right. Failing to shed sufficient DNA into the systemic circulation to allow for comprehensive genetic sequencing, this could lead to a liquid biopsy missing minor but highly aggressive chemo-resistant subclones hiding within the mass.
So what is the surgeon's role in the future?
Therefore, while liquid biopsies will undoubtedly revolutionize staging, significantly reducing our reliance on serial radioactive imaging and radiation exposure, the absolute requirement for an initial, high-quality, architecturally intact tissue sample to establish the foundational diagnosis and grade will remain the strict purview of the surgeon for the foreseeable future. We provide the map, they monitor the territory.
A well-reasoned, rigorous, and highly defensible conclusion. Candid, your grasp of the anatomical, pathological, and operative realities of this disease is commendable. You have successfully navigated the fundamental basic sciences, the critical appraisal of the evolving evidence base, and the demanding clinical scenarios expected at the exit fellowship level. This concludes our academic review. For those of you listening, this deep dive underscores a vital truth. Surgical mastery requires not only technical proficiency with a scalpel in the posterior triangle, but a profound, constantly evolving understanding of the molecular pathology driving the very disease we seek to treat. Thank you for your participation.